Hello everyone and welcome back to Biomed Prep. If you're preparing for Obstetrics and Gynecology OSCEs, clinical exams, or board assessments, this video is going to be extremely helpful. In today's session, we'll be working through multiple OBGYN stations exactly the way they appear in clinical exams. For each station, I will first present the questions just like an examiner would. When a slide appears that only contains questions, pause the video and try to answer them yourself before we move on to the explanations. Active recall like this is one of the best ways to prepare for clinical exams. If you find these videos helpful, please like the video, subscribe to Biomed Prep, and share it with your colleagues. It helps the channel grow and allows me to continue producing free medical education content. And as always, this material is for educational purposes only and should not replace clinical judgment or specialist consultation. Let's begin with Station 1. In this station, you are shown an abdominal examination of a pregnant patient. The questions are: what are the 4 maneuvers demonstrated in the examination? What are grips A, B, C, and D, and what does each determine? What risks or discomforts can occur during the examination, and how can they be mitigated? What are the possible fetal presentations and their associated complications during labor? Pause the video now and try to answer these questions before we go through them together. 4 maneuvers demonstrated in the examination. These are the Leopold maneuvers, which are a series of abdominal palpation techniques used during antenatal examination to determine the fetal lie, presentation, and position. They are performed in 4 sequential steps. Grip A is known as the fundal grip. The examiner palpates the uterine fundus. This helps determine which fetal pole is present in the fundus. A round, firm, palatable structure indicates the fetal head. A softer, irregular mass suggests the breech. This helps determine whether the fetus is in cephalic or breech presentation. Grip B is known as the umbilical grip. The examiner palpates the sides of the uterus. The goal is to identify the fetal back. The back feels smooth, firm, and continuous. The limbs feel irregular and nodular. Identifying the fetal back helps determine fetal position and where the fetal heart sounds will be best heard. Grip C is known as the Pollux grip. This grip assesses the presenting part above the pelvic inlet. The examiner grasps the lower abdomen just above the symphysis pubis. This maneuver determines whether the presenting part is cephalic or breech, whether the head is engaged or still mobile. Grip D is known as the pelvic grip. In this maneuver, the examiner faces the patient's feet and palpates the lower uterus from both sides. This assesses descent of the presenting part, degree of head flexion. A well-flexed head usually indicates normal progression for vaginal delivery. Risks or discomfort during examination. Although Leopold maneuvers are generally safe, some risks or discomforts may occur. Maternal discomfort. This may occur if excessive pressure is used. To reduce discomfort, explain the procedure clearly. Use gentle palpation. Reassure the patient throughout the exam. Uterine irritability or contractions. Excessive manipulation can stimulate contractions. To prevent this, use minimal pressure. Stop if contractions begin. Fetal distress. Prolonged examination may cause transient fetal distress. To reduce risk, keep the exam brief. Monitor the fetal heart rate if needed. Infection risk. If the membranes have ruptured and a vaginal examination follows, infection risk may increase. Therefore, sterile technique should always be used when appropriate. Presentation and associated complications in labor. This is the most common and safest presentation. Possible complications include prolonged labor, cord prolapse if the head is unengaged, shoulder dystocia in large babies. In breech presentation, the buttocks or feet present first. Complications include cord prolapse, head entrapment, birth trauma. For this reason, many breech deliveries require cesarean section. In transverse lie, the fetus lies horizontally in the uterus. This leads to obstructed labor, increased risk of uterine rupture. A cesarean section is mandatory in this situation. In this station, you are asked to assess fetal heart sounds. The questions are: describe the standard procedure for listening to the fetal heartbeat. Looking at the image provided, what is the nurse doing wrong? Pause the video here and attempt the answers before continuing. Standard procedure for auscultating the fetal heartbeat. First, always begin with professional communication. Greet the patient and introduce yourself. Explain the procedure and obtain consent. Ensure privacy using curtains or blinds. Position the patient comfortably and expose the abdomen from nipple line to pubic symphysis. Inspection. Stand on the right side of the patient. Observe size and shape of the gravid uterus. Surgical scars. Striae gravidarum. Then lower your eye level to just above the abdomen to observe uterine contractions, fetal movements, palpation. Next, perform abdominal palpation to determine fetal lie, fetal presentation, fetal position. You should also palpate the fundus and measure the symphysiofundal height. Auscultation. After determining fetal position, you can identify the best location to hear the fetal heart. The fetal heart is usually best heard at the level of the fetal anterior shoulder. Place the fetoscope or Doppler at this location and listen carefully. Ensure that your hands are not touching the device, otherwise you may hear your own pulse rather than the fetal heart. What is the nurse doing wrong? In the image, the nurse has her hands touching the fetoscope. This is incorrect because it may cause the examiner to hear their own pulse rather than the fetal heartbeat. The questions are: define the third stage of labor. What is prolonged third stage of labor? Identify the placental abnormalities labeled A, B, and C. How many arteries and veins are in the umbilical cord? What is the average weight of the placenta at term? What is the average length of the umbilical cord at term? Pause here and try answering before continuing. Third stage of labor. The third stage of labor is the stage that begins after the delivery of the baby and ends with the delivery of the placenta and membranes. This stage is crucial because postpartum hemorrhage most commonly occurs during this time. Prolonged third stage of labor. A prolonged third stage occurs when the placenta has not been delivered within 30 minutes after birth of the baby. This increases the risk of postpartum hemorrhage, retained placenta, infection, placental abnormalities. The abnormalities shown are a succenturiate lobe, an accessory lobe separate from the main placenta. B. Circumvallate placenta A condition, where the placental membranes fold inward. C. Velamentous cord insertion. The umbilical cord inserts into the membranes rather than directly into the placenta. This can increase risk of vasoprevia and fetal bleeding. Umbilical cord vessels. The umbilical cord contains 2 umbilical arteries, 1 umbilical vein. A useful memory trick is AVA, artery, vein, artery. Placenta weight at term. The average placental weight at term is approximately 500 to 600 grams. Umbilical cord length at term. The average cord length at term is about 55 centimeters. Mention 2 types of episiotomy. Which structure is cut during the commonly performed episiotomy? Mention 2 indications. Mention 4 complications. Pause the video and attempt the answers. Types of episiotomy. The 2 most common types are midline episiotomy, mediolateral episiotomy. Mediolateral episiotomy is often preferred because it reduces the risk of extension into the anal sphincter. Structures cut. The transverse perineal muscle is commonly divided during episiotomy. Other structures may include vaginal mucosa, perineal skin, perineal fascia. Common indications include prolonged second stage of labor, shoulder dystocia, breech delivery, instrumental delivery. Complications may include infection, hematoma, hemorrhage, dyspareunia, rectovaginal fistula. Name the investigation. Give 2 indications. Give 2 contraindications. What is the diagnosis shown? What organism commonly causes the condition? Pause and answer before continuing. Investigation. The investigation shown is a Hysterosalpingogram, HSG. This is a radiological procedure where contrast dye is injected into the uterus and fallopian tubes to evaluate patency. Indications. 2 common indications include investigation of infertility, assessment of uterine abnormalities. Contraindications. Contraindications include pregnancy, active pelvic infection, allergy to contrast dye. Diagnosis. The image demonstrates bilateral hydrosalpinx, which refers to fluid-filled, dilated fallopian tubes. Common causative organism. A common organism associated with this condition is Neisseria gonorrhoeae, a major cause of pelvic inflammatory disease. Properties of a good sharps container. When should it be discarded? Rules for safe handling of sharps. Where is the container disposed? Pause the video before continuing. Properties of a sharps container. A proper sharps container should be puncture-resistant, leak-proof, clearly labeled with biohazard symbols, fitted with a secure locking lid. When should it be discarded? The container should be discarded when it is 3/4 full to prevent needle stick injuries. Rules for safe sharps handling. Important safety rules include never recap needles. Dispose of sharps immediately after use. Do not bend or break needles. Keep the container close to the point of use. Disposal. Sharps containers must be disposed of through licensed biomedical waste management systems according to hospital regulations. Name this presentation. Name 4 risk factors. Name the procedure you do for this patient and mention 3 prerequisites for it. Mention 4 benefits of doing a speculum exam for this PT. Mention 4 benefits for us. Pause the video and attempt the answers. Presentation. Breech presentation. Risk factors include multiple pregnancy, polyhydramnios, uterine abnormalities, prematurity, procedure, sterile speculum examination. Prerequisites include avoid digital vaginal examination until membrane status is confirmed. Obtain informed consent. Ensure resuscitation equipment is available. Benefits of speculum exam. Confirm rupture of membranes. Detect cord prolapse. Assess infection or discharge. Reduce infection risk compared with digital exam. What is the name of the condition in this image? Mention 4 risk factors. Mention 3 fetal complications that can occur. Mention 4 maneuvers to deliver the baby in the order they are performed. Pause the video and attempt the answers. Diagnosis. Shoulder dystocia. Mention 4 risk factors. 2. Maternal diabetes, gestational or pre-existing. Macrosomia, fetal weight greater than 4 kilograms. Prolonged second stage of labor. Previous history of shoulder dystocia. Mention 3 fetal complications that can occur. 2. Brachial plexus injury, e.g., Erb's palsy. Fracture of the clavicle or humerus. Hypoxic ischemic encephalopathy, due to prolonged delivery. Management maneuvers in order. McRoberts maneuver. Suprapubic pressure. Wood screw maneuver. Delivery of the posterior arm. What is shown in the image? What is the cause of this condition? How to avoid this complication? How to suspect this complication antenatally? What is the preferred mode of delivery? Pause the video and attempt the answers. What is shown in the image? Interlocking twins. What is the cause of this condition? Monochorionic twins. Shared placenta increases risk of entanglement. First twin in breech position and second twin in vertex position. Premature rupture of membranes leading to entanglement. Uterine hyperstimulation during labor. How to avoid this complication? Elective C-section for breech vertex twin presentations. Careful monitoring of twin positioning in late pregnant. Avoid artificial rupture of membranes in twin deliveries. Controlled delivery of the first twin to prevent sudden movements. How to suspect this complication antenatally. Ultrasound findings of twins in breech vertex position. History of monochorionic twins. Reduced fetal movement of one twin late in pregnancy. Abnormal Doppler flow suggesting entanglement. What is the preferred mode of delivery? Emergency C-section is required if interlocking is detected during delivery. You have been assisting Mrs. X with her labor for 12 hours. It has been an uncomplicated labor and she has progressed well. Now she is fully dilated and the head has descended to the perineum. She is pushing well and the birth is imminent. Write in point form how you would perform the 3rd stage of labor. Steps of active management of the 3rd stage. Administer 10 IU oxytocin IM. Perform controlled cord traction. Wait for signs of placental separation. Deliver placenta gently. Inspect placenta for completeness. Massage uterus. Check for genital tract tears. Monitor maternal vitals. Estimate blood loss. Document findings. This approach reduces risk of postpartum hemorrhage, the leading cause of maternal mortality worldwide. And that brings us to the end of today's OBGYN OSCE Station Review. If you found this video useful, please like the video, subscribe to Biomed Prep, and share it with your colleagues who are preparing for their clinical exams. Consistent practice with OSCE stations like this is one of the best ways to build confidence before your exams. Thank you for watching, and I'll see you in the next Biomed Prep session.